So hi, I'm Andreana. I'm also a medical student at the University of Western Australia, but here today representing the Rural Clinical School of Western Australia. Now, I'm here to talk to you about our experience in implementing a type 2 diabetes screening algorithm for Aboriginal and Torres Strait Islander adolescents aged 10 to 14 in the Kimberley region of Western Australia. Before I start, I'd just like to thank the Rural Clinical School and also ACRM's sponsor of student programs who've both supported my attendance at the conference, so thank you very much for that. And I'd also like to acknowledge the local custodians of the land, the Larrakia people, and pay my respect to their elders, past, present and emerging. So to give you a heads up of what's to come, I'm going to talk about the importance of screening for young onset diabetes in Aboriginal people, the value of using HbA1c as a screening tool, some challenges that we experienced in implementing a diabetes screening algorithm, and then some of the measures that we found improve screening. And just to note, for the purpose of this presentation, I'll use the term Aboriginal to refer to both Aboriginal and Torres Strait Islander people, as the majority of First Nations people in the Kimberley are Aboriginal. And also when I say diabetes, I mean type 2 diabetes. So by way of background, this project is part of a broader project called the Kimberley Investigation and Description of Type 2 Diabetes of Young Onset, or the KIDDI project, with young onset being anyone under the age of 25. The purpose of the KIDDI project is to describe the current situation of care and outcomes for people in the Kimberley with young onset diabetes. And the reason we want to do that is because we think we can do better. The purpose of the part of the project that I'm speaking to you about is to improve screening for young onset diabetes. This is important because young onset diabetes is increasing. It generally has an asymptomatic presentation, which is often only picked up as an incidental finding. And crucially, we know that it's a more aggressive phenotype of diabetes than adult onset diabetes, and it's associated with a much faster progression to complications. Now, in the Kimberley, there are two regional guidelines that govern screening for young onset diabetes. The first is an adult guideline that covers ages 15 and above. And since 2015, this guideline has recommended using only HbA1c testing, including use of point-of-care HbA1c in both remote and regional centres, due to a Kimberley-based study which found that HbA1c was more effective at picking up diabetes in its local population than traditional blood glucose level tests. The second is an adolescent guideline that covers people from age 10 to 14, and that was the guideline that was the primary focus of this study. Now, this guideline hasn't yet been updated, and at present it recommends opportunistic screening of high-risk patients using traditional blood glucose level tests, including diagnosis with an oral glucose tolerance test. So we wanted to find out if simplifying the 10 to 14-year-old screening algorithm, including introducing use of HbA1c, would improve screening in the 10 to 14-year-old age group as it did for people aged 15 and above. Now, a bit of additional context here is that HbA1c still isn't universally accepted as a testing method in adolescents due to concerns that it isn't sufficiently sensitive in this demographic and this age group, and it might miss some cases. So in Canada and the UK, for example, HbA1c is not recommended as a diagnostic tool in anyone under the age of 18, but in the United States they've been using it to screen people from age 10 since 2010, and it's also recommended by the International Society of Pediatric and Adolescent Diabetes. So we wanted to see if HbA1c would be an effective screening test for adolescents in the context of the Kimberley. We also wanted to find out what things helped and what things hindered implementation of a screening algorithm. And finally, we took the opportunity to review screening rates in ages 15 to 25 in accordance with the adult algorithm, which at the time of this study had only been in place for less than a year. So as far as methods, the initial stages of establishing a project team and obtaining ethics approval had all occurred before I joined the project. But it's important to highlight here, as part of that process, support was obtained from the Kimberley Regional Committee that approves research into Aboriginal health, and the project is also supported by the Aboriginal community-controlled health services throughout the Kimberley. So for our first aim to improve screening, we developed a screening algorithm for 10 to 14-year-old Aboriginal adolescents, which was piloted for 6 months at the 2 primary healthcare services that were operating in the Kimberley town where I was based at the time. These services included an Aboriginal community-controlled health service, as well as a GP service that was run out of the local hospital. Now, in addition, we included the remote clinics that both of these services covered, as well as the hospital's emergency department, due to the large number of presentations to the ED that were of a primary care nature. Staff at the health services were educated about the algorithm during routine clinical meetings and were asked for the duration of the pilot to both use the 10 to 14-year-old algorithm and also to record their reasons for screening for all patients aged 10 to 25. We then conducted an audit of the electronic health records at the 2 services for the 6-month period of the pilot and compared the results of that to a 6-month period from before the pilot. And Aboriginal patients were counted in the audit if they'd had any form of screening test during one of the periods, but they weren't included if they had an existing diagnosis of diabetes. To determine enablers and barriers to implementation of the algorithm, I conducted a series of interviews with staff from the health services. The interviews were semi-structured. They were conducted as a mix of group and individual interviews, and they were held about halfway through the pilot and then again towards the end. So this is the algorithm that we trialled, and it was developed on the basis of 2 things. The first was a literature review of published best practice in the area, including screening for diabetes in Aboriginal Australian adolescents, as well as use of HbA1c in adolescents. And secondly, we consulted on an early draft of the algorithm with staff at the health services, with regional GPs, physicians and paediatricians, and also with staff from the Endocrine Tertiary Referral Service at Perth Children's Hospital. So this is the outcome of that process, and essentially it recommends firstly identifying if a patient is high risk on the basis of a set of listed risk factors. Then if the patient is high risk, to take a capillary blood glucose level, and if that is 5.5 millimoles per litre or above, to proceed to diagnostic testing via either a venous blood glucose level pathway or an HbA1c pathway. And the HbA1c pathway gives you the option of an additional screen using a point of care HbA1c before going on to do the venous HbA1c. So a quick synopsis of the results of screening was that at the Aboriginal Health Service, screening went up significantly in the 10 to 14-year-olds. It was already pretty good in the 15 to 25-year-olds, and it stayed about the same. And at the hospital, there were low rates of screening in both periods, and again, there was no change. So in a bit more detail, firstly at the Aboriginal Health Service, in the 10 to 14-year-olds, initial screening using a capillary blood glucose level increased from 22% to 36% of Aboriginal patients, which was a statistically significant increase, and total patients in both of those periods was about 135. In addition, follow-up venous testing increased from 0 patients in the pre-pilot period to 14% of screened patients in the pilot period. Now, of note, all of the venous tests that were conducted in the pilot period were HbA1c tests. The most common reason for screening in this age group was routine observations that were taken by a nurse or Aboriginal health worker before the patient went on to see a doctor. Now, only a handful of patients were screened in response to documented risk factors. So these results show us, firstly, that HbA1c was preferred to blood glucose level testing, and that was a finding that was later supported in interviews. And secondly, a lot of patients weren't screened in accordance with the algorithm. Firstly, not being screened for risk factors, but secondly and importantly, not receiving diagnostic testing in response to an elevated point-of-care blood glucose level. Now, the reasons for this came out in interviews, which I'll come back to shortly. In the 15 to 25-year-olds, we were pleased to see that screening was already happening and remained similar during the pilot, with about half of patients being screened. And there were total patients in those periods were about 245. The most common reason for screening in this age group was general health screens, such as via the Medicare 715 health assessment. And what was of interest here was that use of venous HbA1c actually went down during the pilot when compared to the pre-pilot. And this appeared to be because a local charity had run its annual general health screening program during the pre-pilot period, which led to a large number of patients being screened in a concentrated period of time. So just a quick word on the hospital. As I mentioned, our results showed that there was low rates of screening at the hospital with no improvement during the pilot. It's likely that there was some screening happening that wasn't picked up in our audit, as the emergency department presentations were often only recorded in paper files, and our audit only considered electronic records. However, it was also informative to learn that there were certain organisational characteristics at the hospital which made screening more difficult there than at the Aboriginal Health Service. So, for example, at the GP, there were shorter appointment times than at the Aboriginal Health Service. Patients saw a doctor directly without having a set of observations first taken by a nurse or Aboriginal health worker. And as you'd expect, ED staff said that they were unable to screen when it got too busy in ED. So these were the sort of factors that probably contributed to screening occurring less at the hospital than at the Aboriginal Health Service. As far as enablers and barriers to implementation, we had 30 staff from both services participate in interviews, and overwhelmingly staff said they supported screening for young onset diabetes, but they had a lot of reasons that prevented them from using the algorithm. And one of these reasons was that the algorithm was too complicated, both in appearance, which made it hard to follow, but also in having the two separate screening pathways, with staff expressing a clear preference for HbA1c. A second reason was that people were reluctant to conduct screening in the younger age group, and this transpired at every step of the screening process. So firstly, when it came to determining if a patient was high risk, lots of practitioners preferred to use their own judgment rather than the risk factors that were listed in the algorithm. However, most practitioners appeared to rely on whether or not a patient was overweight, and they didn't take into consideration other prevalent risk factors, such as whether a patient has a first-degree relative with diabetes. Then in terms of screening, there was a fear expressed by some patients and their parents, as well as some staff, that we might be causing unnecessary harm to patients by commencing screening at such a young age. Now, in these cases, we found that staff were reluctant even to go on and perform a capillary blood glucose level test. And on a similar note, we also found that locum staff were reluctant to screen in the younger age group, given that that isn't usual practice in Perth. Then at the stage of venous testing, there was again general reluctance to proceed to the venous testing. This transpired as a tolerance for high capillary blood glucose results, which were often explained by things like the patient was unwell or that they just had something to eat. Now, these patients were usually advised to come back for screening at a later date, either verbally or by the Aboriginal Health Service's recall system. However, with only a couple of exceptions, the patients did not return for the follow-up testing. So we know that advising patients to come back for screening at a later date doesn't work in this patient population. And then there were barriers that we know affected the implementation of the adult algorithm, and probably influenced by the remote and rural setting, such as the challenge of ensuring locum staff all know about the algorithm, and then the difficulty of ensuring all staff are consistently following that algorithm. And then finally, staff at the services, at least that I was working with, were concerned about the reliability of the capillary HbA1c machine, and so they preferred not to use it. Unfortunately, in this case, use of the capillary HbA1c could have mitigated some of the concerns that staff had about proceeding on to the venous testing. And this is because point-of-care HbA1c wouldn't have been influenced by the same things that influence the point-of-care blood glucose levels, such as the fact that the patient was unwell on the day or that they'd just eaten. So performing a capillary HbA1c could have acted like an additional screen to identify patients who really warranted receiving a venous HbA1c, and ultimately might have meant that more patients who should have received diagnostic testing actually had it done. So this feedback gave us useful insight into what measures do improve screening, particularly in the 10 to 14-year-old age group. So for example, having a simple guideline that only offers one screening pathway with a preference for HbA1c, and educating both patients and staff about evidence supporting the algorithm to ensure that they're willing to engage with it. We also know that certain organisational practices can improve screening, such as use of capillary HbA1c testing, nurses and Aboriginal health workers recording basic observations from patients before they go on to see a doctor, and strong organisational leadership to encourage consistent application of the algorithm by all staff, including effective use of recall systems. And finally, dedicated screening programs improve screening, with the caveat that it's important that such programs are accompanied by adequate support services to ensure that there's appropriate patient follow-up after the screening program's concluded. So as far as where to from here, we're now in a process of amending the algorithm in response to the results from this study, and this is our current draft. This will then be fed into a formal review of the entire 10 to 14-year-old guideline, and that will occur via the Kimberley Aboriginal Health Planning Forum. And then the final product will be published on the Kimberley Aboriginal Medical Services website, along with the other Kimberley Clinical Regional Guidelines. So that's a summary of the study. We hope the findings will be useful for other remote and rural health services that are looking to implement or improve their screening for young-onset diabetes. So just to reiterate again, young-onset diabetes is an aggressive disease, and it's important to screen for it in high-risk populations. In a remote and mobile population like the Kimberley, HbA1c is a more effective screening test than traditional blood glucose level tests. And finally, there are a number of practical measures that can be implemented which help to improve screening. So thank you very much for listening. Has anyone got any questions?
No questions?
Thank you.
You got one at the front.
So could you just tell us exactly where we can, you said it's going to be published on the...
Yeah, so the Kimberley Aboriginal Medical Services publishes the regional clinical guidelines online, and so once we've been through the process of updating the guideline, it will be published on that website. Yeah.
Thank you.
Andreana, just quickly, as an ED doctor from the Kimberley, we always is constantly seeing uncontrolled and poorly compliant diabetic patients. This research is fascinating and interesting. I'm wondering, however, the next step is, are you aware, because I'm not, of what is available in the Kimberley region for ongoing management and education of our patients to actually improve their quality of life and reduce the long-term complications which we are seeing on a daily basis?
So I will say that's probably out of the scope of my expertise, but it is tricky managing young patients with diabetes, do understand that. Currently, lifestyle measures are the mainstay of treatment, along with metformin. But recognising the complications and the difficulty of that, we've now included in, see if we can go back. The final recommendation on this algorithm now states that if you get to the point of having like a HbA1c within a range of pre-diabetes or diabetes, to refer on to a paediatrician for management who will have the relevant expertise, I guess, to handle that situation. But yeah, unfortunately I can't give you any more insight than that, sorry. My supervisor?
Thank you.